So we'll get going just by way of a bit of background. So I sort of know a little bit about this. I came from working with Joe at Island Bay Medical Centre as the clinical nurse manager there for almost a couple of decades, to be honest. And then I came to Hauora after being serving on their governance board for 9 years or so, and started up. I didn't want to leave general practice just for the sake of leaving it because I really enjoyed my role. But then I got the call to say, what about this healthcare home model of care? And I went up to Pinnacle and had a look up there and thought, oh yeah, it's got some legs. I think that looks pretty good. So I made the jump and started off the healthcare home program here about 5 years ago. We're now into year 6. And we were sort of like building the plane as we were going, but we had lots of support from our colleagues up at Pinnacle who'd done it before us. And then about 4 months ago, I jumped into the role as Kapiti Community Health Network Manager, which is the first network, and I think Mabley might have touched on that this morning, first network to be set up here for Cape Coast. And then I've been in this role for 11 days now as General Manager Clinical Services, so I've jumped around a bit. But so I was asked to fill in for Wendy, who can't make it, unfortunately. She's unwell today, so I'm happy to do so. So we'll just launch into it. So I guess just in terms of introduction, the things that I'll be covering are the proactive care domain of the model, and talk about wellness planning, who wellness planning is for. We sort of used to call it year of care planning, but the new changes have come via the collaborative, so we've changed the language that we're using. How do you find the right people for wellness planning, and what are some of the key success factors? We talk about equitable care planning and what that looks like, and what the process looks like. So often I think we got the concept, and it'll be fair to say that we've had a few iterations of care planning, and for those of you who are of my generation, we've gone through sort of Care Plus, and then we get to this sort of care planning, and we get the question from general practices, what's the difference? Is it just sheep in another, is it just, you know, sheep in another clothing, or whatever the saying is? But it's quite different, so we can talk through that as we go through the process. And then what tools are there to support the planning process? So who's wellness planning for? Well, it can be anybody really, but in terms of sort of defining it a bit better than making it so broad, is anyone with a high healthcare or social care need actually. Those who are frequent attenders to the general practice or after hours or ED, so those ones that might need some more a planned approach rather than a reactive approach. Complex needs, anyone on an LTC, long-term condition plan, or having a single progressive diagnosis, something like MS, or something that is going to lead to something that requires a bit more support, and prioritisation for Māori Pacifica and other communities. So that's a key consideration when you're selecting patients for wellness planning. And how do you go about, so I guess this presentation is sort of a little bit sort of the how-to, so I'm not sure if that's quite hitting the mark. You probably might already know this, but this is how we select our patients, or the how-to that we do here at Hauora. So where can you find the right people for wellness planning? So we've been sort of fortunate that Hauora, we've got sort of the use of a risk stratification tool, and many of the PHOs will have a similar sort of thing. The one that we've got was developed by Sapere, and what that can show us is those patients most at risk of a hospital attendance in the next 6 months. We can use the practice population data, and all our practices have really good access to that. Clinical judgment. So we say with the risk stratification tool, it's just a tool. There can be people that are missed off that, and we recognise that, particularly people with mental health conditions, because sort of picks up on people with a number of long-term conditions or polypharmacy, so there'll be some that are underrepresented. So we say use your clinical judgment. You don't have to exclude anybody. Escalation triggers, those ones that you might realise that they might have a decline in the near future, and other providers that may bring people to the party. So it could be, they could be referrals or people from district nursing or community services that say these people would be really good to be on a year of care or wellness plan. This was the predictive risk algorithm that I was talking about, and probably very familiar to a number of you. So we're looking at the top 7% predominantly. So we sort of, some of the practices, and rightly so, said, what about this next percentage, and what about preventative and agree that's a good point. You can take patients from there, select patients from there as well. But we know that from that top 7% it accounts for 42% of hospital attendances, so that really does warrant our attention. We acknowledge that in this top 2% there'll be a number of patients who are palliative, so they may already have a really good care plan or plan of care wrapped around them. So again, the predictive risk tool is just a guide of sorts. And I guess then the practices in a practical sense need to sort of work out what their approach is going to be. And very much this, the Wellness Hauora approach, care plan is about holistic planning. So it's less about disease specific or disease focused. So you might, it's not the same as a diabetes annual review, although that will be a subset of a wellness plan. So it's less disease specific and it's more about looking at the patient as a whole rather than as an individual sort of disease. Whether it's going to be a team approach, so now we have a plethora of people in our general practice team, so we've got health improvement practitioners, health coaches, primary care practice assistants, nurses, nurse practitioners, so it's broad and wide. So and we've got clinical pharmacists as well. So the question is, how are we going to involve the rest of the team? And is it appropriate? And it's about seeing the right person at the right time. Is it going to be nurse-led? Or is it going to be a combination of the nurse sees them first and then the GP comes in? Or is it going to be divided depending on the patient need, which is often a really good idea, because not always they need to see the doctor on every occasion. So every practice will have a different way of doing it and divvying up the appointment times. And then what models of care could you use? So you could use the Te Whare Tapawhā model, which is a really favourite of some of our Māori health providers. So we leave it pretty open and broad. We've got a sort of a care plan template that we use, but we say to the practices, if you can improve on that, please do. It's a pretty basic outbox document in lieu of having a shared electronic care plan, which we're sort of working towards with Medtech, and Indice has it inside it, but we just need to make that more operational about how we can invite external members. And I guess considerations, what's on top for the person, absolutely the first question that you ask, what matters to them. That probably won't be any surprise to you, but it's less about us and it's more about what they need. And getting some sense of the literacy, level of literacy and how you're going to explain things. Who else is involved in the person's care and who needs to be involved. So getting a good idea about the people that are wrapped around them or not, and who you might want to involve in the care planning team. What's the understanding of their health? So part of this the process that we have, we use the Partners in Health scale that some of you may be familiar with, or probably all of you. I'll show that to you a little bit later on. And how does that inform the wellbeing planning? So the success factors, I guess, of care planning is patient-led, in collaboration. An electronic plan is ideal. Does anyone have an electronic care plan that you use? I think Northland are using electronic care plan.
Northland is using Whānau Tahi.
Whānau Tahi.
It's not a great tool. None of our general practices like it. And don't go throwing it at the
I absolutely agree. So, warning to all, avoid Whānau Tahi.
Okay.
Not
trying to
the
get
doors
this
playing
fail
one.
slow.
Right, okay, well that's good feedback. Thanks for sharing. I think something that the collaborative have recognised actually with the shared electronic care plans is that the vendors, there's no sort of understanding that the vendors, if a patient moves from your care plan to one of ours, that all of that goes across. So the patient, this is the cohort of patients that you really need them not to have to retell their story because it's so complex and there's so many things going on. So that's something that the collab have been working with the ministry to see if we can get some sort of lines in those vendors' sort of contracts or service specs. The plans are a live document, so they're not just one standalone annual assessment and off you go. So the team should be checking in with the patient and it's all patient specific. So when I talked about Care Plus, that was sort of pretty much you will bring them in 3 monthly regardless if they needed to come in, because that's the way that we got funded to do it. And it sort of worked quite nicely for the practice team. It was all nice and neat in a box, and they got their prescription every 3 months, and that was really easy to do for us. But this is a more based on patient needs, so you might have someone come in once a week for 2 weeks, and then you might give them a call a month later or 2 months later, depending on patient needs. So it's not in a nice tidy box as what it once was. So that's some of the challenges, I guess, for the practice teams when they're trying to implement this. What works well is that there's one person that holds the ring over the patient care, so we call it a care plan coordinator, for want of a better word. And we talk about the Partners in Health scale, the opportunity for a patient to complete that, which is essentially a self-management tool. And this is about the Partners in Health scale. Is there anyone using this in the room? Wairarapa practices. Anybody else? No. So the collab sort of looked at this collectively and thought this is the first evidence-based tool that we have to manage, self-manage, to monitor or get an idea of how a patient feels that they are self-managing themselves. So what it does is it's evidence-based. It comes from Flinders University in Australia, and we've adopted it. And what it does is we can have an annual sort of get the patient to do this year on end. And what it does, it can show improvement in how the patient feels that they're self-managing in about 12 different areas. I'll show you an example. So the way that this can be done in terms of timeliness, they can send it out to the patient, or the patient can complete it when they come in. It identifies what's on top for the whānau or the patient. So that's really good in terms of not so much saving time, but targeting your conversation to what the patient wants to talk about. If a patient comes in, you say to them, "What are your goals?" They'll be like, "What?" Because if someone asked me that, I'd say the same thing. Do you know? So you want to say what keeps you awake at night, or what would you like to work? What matters to you at the moment? What's on top? Andrew Miller tells a really nice story, and I'm not sure if any of you have heard his story about it. He won't mind me telling you about a patient of his. He's a GP in Northland, who he'd known for many years, more than 15 years, and after he's a real advocate of care planning. And a patient came in and he just changed the first question that he asked this patient, and he said, "What's on top for you?" And this patient had diabetes, HbA1c off the scale, and probably never really sort of got on top of that. And so he just, in one consultation, he turned it around and he said to the patient, "What keeps you awake at night? What matters to you?" And the patient says, "I've got a chronic gambling problem." And Andrew's like, "Oh my gosh, I'd never known. It's been 15 years. And the thing is, he says, I can't help you right now, but I can get you some help." So I think one of the concerns when we had rolling this out, that the nurses are like, "Oh my gosh," not only nurses but GPs, when I ask this question, it's like Pandora's box. We don't know how to deal with all the answers. We're good at blood pressures and all the rest of it, but what happens if something's a little bit left field? And this is where the model butts in really nicely with the MDT meetings, because your MDT team are wider than your general practice team, and so you've got lots and lots of support and resources that you can call upon. So just flipping that, or just changing that first sentence when the person sat in front of him, just changed the whole outcome. He came back subsequently about 4 months later and said to Andrew, I'm really keen to talk about my diabetes now. So it'll be known to all of you that this is exactly what this is, the good thing that this is about. It guides clinicians, and we can measure progress over time, which we haven't had before. So this is what it looks like. There's two versions. So there's a pictorial version like this, which some of the practices prefer, or there's a more sort of text-heavy version. And essentially they just go and indicate where they fit on the scale. And something like, how much do I know about my medications? If they put 2, little, and then you go, how much would you like to know about your medications? And they go, 2. It's like, move on. It's not about us wanting them to know. If they don't want to know about it, that's fine. If they do, we've got the clinical pharmacist that we can refer them to. So it's about getting an idea. So once the practices have done this, we've got a little screening template that they just pop the numbers in, and then they can look year on year, and they can look across all of their patients in the practice, or they can look at individual patients about how the patient feels they're self-managing. So I recommend having a look at that. It's invaluable. We've never had, I guess, when we were practice nursing, and you'd say, no, I'm not sure, I don't think they're really managing that well or self-managing, but it was a hunch, and we only see this much of the patient, so this is a much better tool for the patient doing it themselves. Equity and wellbeing is pretty high on our list, and just in terms of the program, looking at it to see if it has an equity lens. Like if I could redesign our program, I probably would, again, just in hindsight. So in year 3, we put an equity lens on our funding. So it was a 3-year funded program. It's now into its 6th year. So we got to year 3 and thought we needed to change the funding model that went to the practices and weight it based on patients Māori, Pacific or high needs. And we also, as part of our performance framework, when the practices get a bit mature into the program, we have an equity weighting on these wellness plans. So we expect 30% of those plans to be for Māori or Pacific. So we put a weighting on that, and they get funding based on their performance, which is really important for us. What's really important, I guess, is the practice having an understanding of their profile or their population. It's interesting to me, sometimes you'll go into a practice and say, what percentage of your patients are Māori or Pacific? And I'm like, ooh, I'm not too sure. And like they're working in it every day, and it's not a slight on any of the practice team, it's just that we've got really good data, it's just making sure our practice team members have they've all got access to it, but they're actively looking at it and making sense of it. And we've got filters that we can use to prioritise Māori and Pacific. And also the practice considering other ways, so you're probably all familiar with the shared medical appointments, rather than the 15 minutes rinse and repeat consultations that don't work for everybody. So we, particularly our Māori health providers, are using this model really well. We had about 12 Māori men in a room that all had gout, all different generations, but all the same whānau, all sharing each other's medications and borrowing from each other. And then they came together and it was amazing. We looked at their uric acid levels and just a different learning, like there's safety in numbers. There was less of that sort of power, sort of the GP sitting there telling you what to do. It was a long sort of 90-minute consultation. It was amazing. So maybe saying to the practices, if you consider doing your model, particularly with these patients with long-term conditions, they require longer appointments than your 15 minutes rinse and repeat. I think Mablish might have showed you this slide. So this is, I was going back, every practice has a view of what their population looks like, so there's no excuse for them not to know. We've got those patients who have got 3 or more long-term conditions. This is the predictive risk modelling that I talked about, and they can click on any one of these and a list will come up of patients. Okay, this is a bit of the process stuff. So I know people are like, oh, well, it's all very well and good, but how do you do it? So this is how we have adopted it. So we get the practices to work out how to identify the patients, how you invite the patients, and the benefits. So this little thing, and Joe, you might remember this when we started back at Island Bay, it was such a simple thing. So we did a wee letter about what the benefits of the patient are for a wellness plan. We called it Care Plan back then. But we it was genius, and I got this idea actually, just to say it was a little bit genius, from a newsletter that I got from my son's school. And there was a questionnaire in it, and I'm like, okay, get out the letterbox, and another questionnaire. But it had a little individualised tea bag in it, and it said, this will take you as long as it takes to have a cup of tea. It was like genius. So I'm like, okay, so I did that and I filled in the questionnaire. So we tried the same approach with this. No lie, the people that came in, the first thing they said is, oh my gosh, that cup of tea or that tea bag. And it was just such a selling point they sat down and they actually filled in, I was filling in their partners in health scale. So we sent it all together. So just little ideas. Practices are really innovative in what they do. Decide the duration, who's going to be involved. decide who's going to be the coordinator, and sometimes that can be divvied up in the team depending on if you've got some nurse specialists in this particular patient, although I said it's not disease specific, but if the patient has got diabetes, you might want to have your nurse who specialises in diabetes to take over a cohort of patients. So play to the strengths of the team. And be familiar with the tools. We talked about the Partners in Health Scale, the care plan, and there's one in Indice. And we use coding quite a lot, so know how to code. So it's quite useful for reporting. The DHB are pretty keen on what we're doing, as we are as well. So we get the practices to code when they've done a plan, and also a Partners in Health Scale, and we can see that matched together as one of the system level measures for the Wairapa DHB, actually, Partners in Health. Then it's just about making a plan, decide who's going to monitor the progress, and review and update. So again, not an annual thing, it's like as needed per patient. Setting goals, I won't go over this. This is pretty much everything that you probably already know. We know about SMART goals and making sure that the patient sort of isn't set up to fail from the beginning, making them small and achievable. And of course the resources, so self-management is a big part. And if you go onto the Collab website, this is sort of the Health Navigator has a whole bunch of resources. So you'll be familiar with John Kerwin and all those self-help sort of self-management sites. And also we say the change team, we're pretty good at sort of supporting them. If they want, we'll do some in-house education sessions with them, use our wider PHO, so the Stanford self-management programs. I'm sure many of the PHOs have access to that up and down the country. So self-management plays a really big part. All right, so the next part of this was to talk about, in terms of proactive care, was to talk about MDTs. And just a quick show of hands in terms of the practices that you've got in under your watch. Are any of them doing MDT meetings, multidisciplinary team meetings? Yeah. Okay. So, yeah, sort of, yeah. Okay, that's all right. Sort of, yeah, a few sort ofs. So I guess just to give this a bit of background information, we are pretty fortunate that our DHB, when we set up Healthcare Home, we had a strategic plan that was aligned with what they wanted to do and what we wanted to do. So in terms of community service integration, they were all about that. They put in a lead from the DHB end, and they were all about pushing out their community services teams into general practice as opposed to us having to pull them in. So we were sort of fortunate from the get-go. It didn't go, it wasn't smooth to start with, to be fair. There was a lot of capacity building at the DHB end, so they needed to look across their teams, their Hauora teams and their district nursing teams. They had both had healthcare assistants, so they needed to look about how they might want to share that workforce, because we were then the expectation was that every practice would have an MDT going in their practice every month, and that would be in the practice, and the community services teams would need to go into the practice and be there every month. And then as we built onto 42 practices, as you can imagine, the district nurses and Hauora teams and care coordination are going, how the heck are we ever going to do that? And luckily virtual came along, and so now I think the process that we did is we started off just by engaging the teams, getting them to know each other, and we had probably 6 face-to-face MDTs for the first 6 months, and then we moved into a virtual mode. So the district nurses then got iPads, which they didn't have before. It was all pretty paper-based, so they could zoom into a meeting from a driveway if they'd just gone to a patient to see a dressing. So there were lots of changes from both ends, and both of us sort of spoke a little bit different in terms of language. So the DHB had different acronyms that we did. So we used some of that ADCAR training about how we communicate, even at a basic level, with each other, how we do case presentations. So there's a lot of variability. You'd get one GP up that would talk about the patient was from, Bolivia, and all his family, and at the end there was something like he had this major risk of being vulnerable or he'd fallen, but it was right at the end. So we had to even go back to that and say, this is how you do a succinct case presentation 10 minutes or more, and if it requires 10 minutes or longer, then it goes into a proper sort of case review with whānau and other members. So that's how we sort of started it off. I guess the principles were just to get more integration and engagement with general practice and community teams. We established the MDT meetings. We wanted to enhance services for patients, strengthen relationships and teamwork, and development of tools, a shared care plan, which you won't mention again. We never quite got there. So we developed this, and we're really happy to share any of the collateral. I think the collab might all have it, but it was sort of like a desktop guide, a how-to for MDT meetings. This is just a pretty much a basic process about how we communicate with the DHB about getting patient lists together and who sends what, and we had some strict timeframes around it. Often, they book their time out in advance, and then for a practice to say, oh, we're a little bit busy, we're going to cancel it the day before isn't a good look, and vice versa. So we've pretty well tied that down, that they're respectful on both ends, and if they feel like they can't go ahead with the MDT, they're pretty quick to give us a call, and we can sort of help support them through that. So this is just a bit of the process. So this is only when we had 20 practices. We started with a service managers meeting, so that was myself and some of the members, the key people from district nursing, order services, care coordination. Then we did a bit of a clinical meet and greet. It was quite funny. We started off with one practice, brought everybody in. They had the plunket, all the clinical services, and they had a cup of tea and some sandwiches. And the next practice did like sort of craft beers and pastries, and all got a little competitive about what the meet and greet with the clinical services team was like. But it was a really informal way of just getting to know what each of the services can bring. And then we just started the MDTs, and we just logged them, and we get the practices to code them. So we've got some good data about the number of MDTs, the patients that are discussed, so they can look back and we can monitor the numbers and how well each of the practices are doing. We sort of note the ones that have cancelled and try to work out why that is. Patient selection is a big one. We do get lots of practices going, we have no patients. I've got a population of 10,000. It's like, really? No patients to discuss? And often it's more about process. So we use some of the healthcare home sort of tools, like we'll say things like, how about on your daily huddle, every Tuesday you have an agenda or a little item to say, let's all bring some patients together for an MDT that's going to be in the next 2 weeks, or put some systems in place so it's not up to the one MDT coordinator to have to go around and knock on all the doors and go, any patients, any patients? So it sort of needs to be thought through, but there's some of the sort of challenges that have come up, but we can help the practices with those. This is probably not really for reading right now, it's probably a little bit too much and too much at the end of the day, but just so these are some of the inserts from what's within that wee desktop guide. So it's really important that we've got roles for everybody, just to stop the confusion of who's doing what. So we have a general practice based MDT coordinator who pulls the meeting together, gets everyone in who needs to be there, records the notes in the PMS. Then we've got a MDT coordinator based here, which is Fiona at the back. So any problems, they all call her and email her, and she sorts it out amazingly. And then we've got a lead at the community services team end. This is what it looks like, pretty basic. They just put on the patient's names, which doctor or nurse practitioner they're under, which service that they require. We've also got a section here, we've got the hospice on. Potter Hospice recently have joined, so that's our core 4 teams. I guess the nut that we haven't quite cracked yet is mental health services. So the practices have been pretty innovative. They just sort of invite who they know at the mental health, for the mental health team if an MDT needs to involve them. So we haven't quite cracked that nut, and we're still working on it. So just some photos of getting the best of the MDTs. So these are just the services. We've got the aura, that's who's involved in that. So again, when I say the care planning process sort of maps quite nicely to this, because if a patient comes for a wellness plan and then they've got any of these issues that the nurse feels like she needs support with, then she can bring that patient to an MDT meeting and say, hey, I need some help with, I don't know, family therapy, or I need some help, and you've got the team members. So the people who get invited to the MDT are the ones that are wrapped around that patient. So it could be a whole bunch of different people depending on the patient need. We've got district nursing services, the care coordination, which is our NASC service, and the hospice. And I guess selecting patients for MDT, so how do you get them? Some of them come from the wellness planning. Some of them concerned about how they're going to manage over the next 12 months. Progressive conditions, so that was quite useful for the practices. We did a webinar where we got the leads from the community services teams, because often the patients, the practices didn't really think through any progressive conditions. They sort of thought more of the here and now. So it was really good for those clinicians to come and say, hey, these would be a really good patients to select to come and discuss at an MDT. So that was useful. We've been working on that quite hard. And I guess out of the model, this was the hardest. Proactive care is probably the hardest one to absolutely nail. So I hear what you're saying around the room. It hasn't been the easiest one out of all four, but it requires some work. So again, our PMS, our system, it gives them that population summary overview. They can look at that top 7% at risk of a hospital admission, and they can look by disease state if they want. We've got this, which is quite cool. It's community active referrals. So what that gives the practice a view, a global view of any of the patients that are open on the books to the district nursing or HCH services. So if they're looking for another place to look, they can go. We get that sent to us weekly from the DHB, so they can look and see who's already known to the community services teams. And then, of course, the urgent care reports, those patients that keep turning up to after hours or A&E. So there's a number of ways that they can select patients, and most of them will utilise these. Probably don't need to go through this too much, but these are some of the examples that our community services teams gave to the practices to say, have you considered, could be someone with sort of supranuclear palsy, so they might be deteriorating. And so this actually did spark some, I've got about 5 that I could probably add to the list after they saw some examples. This is I don't know if this is going to work, Amelia. We'll try it.
Introducing ourselves. So I'm Harriet. I'm the nurse manager here at Peninsula Medical, and Kim.
Kim from Capital Coast Care Coordination Centre.
Ben Carpenter. I'm one of the GPs here at Peninsula.
Hi, I'm Sophie. I'm a practice nurse here at Peninsula Medical Centre.
I'm Ellie, one of the GPs at the Peninsula.
Rose Dodd, one of the GPs here.
I'm Mara, clinical pharmacist facilitator that covers Peninsula.
Kia ora koutou, I'm Kate Wild, I'm charge nurse manager for district nursing in Wellington.
And I'm Fiona Begg, one of the liaison nurses for the Wellington Community HCH team.
Ken Louis, one of the GPs at Peninsula Medical.
Thank you. Right, we've got 3 patients to discuss today, so we will start with
Stage 3 chronic renal disease, diabetes, and she's on Novamix 30.
When you have lots of different people in a room from different disciplines, you can get that kind of multi-focus approach and solve problems on the spot, which is really, really helpful.
Finding out what people do and what their role is and what services are available, just understanding the whole system, which has always been a bit, sort of foreign to me before. I think working as in a MDT forum really supports a more holistic approach to health, because you've got lots of different disciplines, different approaches all coming together as one.
I'm pretty sure I did a postural assessment the first time I saw her, and
there's been a couple, and there hasn't been as much as a drop.
as that.
And it's great to be able to meet the primary health practices and meet the GPs and the nurses and other members of the team face to face. It does make communication so much easier and a lot freer.
It's a fantastic way to update, sort of like a 360 view of what's happening for that person. and a really, really efficient way to make decisions and decide things then and there.
So there'll be a system in place before she gets discharged, which I think was Nina's concern. Would we have to do some backup services? So
often they might not be on their own, they might have family members looking after them who also need support and care so that they can continue doing that.
I was just looking to see here if she'd ever attended with somebody other than husband, whether a family member came.
She's got a chronic anemia, iron deficiency anemia, which is thought secondary to both, well, partially a gastritis, so she had chronic.
Obviously the health isn't just about the particular illness or disease that person might present with, it's about everything, isn't it? So, and we often see that housing comes up as an important issue for people affected.
Before she moved to Wellington, she's in a council flat or council house.
And I know from feedback from my district nurses that they've found it really good. They've found subsequent to the MDTs that they've been able to ring up the practice more confidently and speak to people that they actually know, and it makes a huge difference.
Thank you, everybody, very much. Okay, thank you. We'll see you in a month.